Hello, everyone. Thank you very much for tuning into this talk that we as the RCN Society have prepared for you. We hope that this knowledge will be of benefit to your clinical training and as you interact with other clinicians. So the purpose of us doing this talk is to equip you with the necessary skills in order that you be able to present your patients that you've interacted with, that you have taken a history, examined, be able to present this patient to another clinician or another colleague in order to be able to manage the patient accordingly. So the purpose of oral presentations to clinicians is to provide other clinicians with patient information sufficient for them to understand the factors that led to the present illness, something of the person in whom the illness is found, and sufficient detail of the history, clinical findings, and special investigations for the reasoning behind the diagnosis to be appreciated. So it's really important that you be able to develop this skill so that as there are many patients that you have to sort of see, interact with, that the clinician is able to get the most information from your summary and be able to manage the patients accordingly. So this first talk is with specifically regarding MPCHB. So in your clinical years, this will be of most use. So the summary of your assessment to the clinician will include firstly the name and age of the patient, the occupation and place of residence, the relevant medical history and risk factors, the primary presenting problem and duration of the illness, the important associated symptoms, the final diagnosis and differential diagnosis that you gather from your patient, as well as exacerbating and relieving factors. It's really important that the summary is short, succinct, and not more than 3 sentences and should be relevant to the diagnosis of your patient. So firstly, on history. So history, it's really important that you gather a detailed history of the presenting complaint. So you ask the patient what they have, what they experience in their symptoms, and gather other associated symptoms. So if it's pain, you go into more detail with the pain, like Socrates, where is it, when did it begin, any relieving or exacerbating factors, and so on and so forth. As well as gathering relevant past medical and surgical history, the relevant systemic inquiry, important negative symptoms, to show that you ask the right questions to narrow down your differentials. And it's really important that you avoid reporting irrelevant history. It's important to focus on the aspects of the patient's history that is important for your current presenting problem. So on examination, as with all examinations, you start with your general examination. So it's important to report back on the general condition of the patient and the appearance of the patient. If they're wasted, their color, if they're jaundiced, pale, and so on. And it's important to comment on the relevant positive and negative findings, which are of importance. So, for example, using the jackal, so looking at jaundice, pallor, looking at clubbing, cyanosis, edema, and lymphadenopathy. It just forms a nice foundation and be able to cover all the bases in terms of general examination, but it's not limited to these. So it's really important to present the primary effective system first. So important findings and the relevant negatives of that system. So if the patient is presenting with perhaps chest pain, shortness of breath, edema, so you want to focus perhaps on the cardiac system and then report those important findings and the relevant negatives of that finding. If other systems are affected, present the next and note the important negatives here as well. And then the rest of the systems you can do in summary just to cover your bases. So with the investigations, it's really important to start with the bedside tests. So these are easy tests that you can do that are quick and be able to give you a much better picture of what the patient has. So this will include things like dipsticks, that you take at the bedside, and which really provides important information about the patient. Other investigations that you can also do really depends on what the patient has, what you think the patient has. Those investigations will be tailored towards that. So, for example, blood work such as an FBC, a full blood count, a differential blood count, or looking at specific antibodies or serology. Also, imaging is really important as well, such as chest x-rays, CT scans, really important in narrowing down your diagnosis. And so these should be there to really confirm your history and your examination. So narrowing down the differential and confirming your diagnosis as well. And then here you can mention investigations that you have done that you would do to get to your diagnosis. So when you're presenting to the clinician, it's really important that you really gather the information and really make a succinct summary of what you have gathered when interacting with the patient. So when you present to the clinician, these are the few points that you would want to include in your summary, so that you cover everything and you include all the information that is relevant. So firstly, you want to have who is the patient and their socio-demographic context. Secondly, what is the relevant medical history and indication of control of the chronic illness? So, for example, maybe the patient presents with shortness of breath or any other cardiac-related illness. They have a history of diabetes or hypertension. So with that, it's really important to also mention their control of their, for example, their diabetes. So with that, saying that they have diabetes, you would also include perhaps the HbA1c percentage to show how well they've controlled their diabetes, as well as if they've taken their medication or if they've defaulted, and as well as for hypertension, if they have any target organ damage, such as retinopathy or nephropathy. So it's really important to include these things in your summary in order to show the extent of these medical conditions and their control in the patient. And thirdly, then you'll move on to what is currently wrong with the patient. Why is the patient presenting to the hospital at that point in time? Fourthly, what is the most probable diagnosis or diagnoses based on your history and your examination? So you'll be able to formulate that assessment. What are the key history and clinical features that support the diagnosis and diagnoses? And what investigations are done to confirm the diagnosis? So you mentioned this, and then what would you look for, perhaps, or what have you found on investigations to confirm and narrow down your diagnosis? And lastly, what is the management plan for the patient? So here we've included a patient example to just help illustrate better what is expected when you're presenting a patient. So the summary of his patient: Mr. Ennis is a 45-year-old man from Marigold and is a part-time bartender. He has newly diagnosed RVD and was recently diagnosed and treated with cryptococcal meningitis. He now presents with blurry vision, dizziness, headaches, trouble walking, and vomiting, which are indicative of persistent cryptococcal meningitis. So in history of the presenting problem, Mr. Ennis presented with a 4-day history of dizziness and a 2-day history of vomiting, blurry vision, headaches, and difficulty walking. His eyes are also sensitive to light, and he denies having a stiff neck. On medical history, he is a known hypertensive and diabetic on treatment. He was recently diagnosed with RVD, but he is not on ART. His CD4 is 68 and viral load is 46,000. He was diagnosed with cryptococcal meningitis 3 weeks prior and given a 7-day course of amphotericin B and fluticasone. His medication that he's on is hydrochlorothiazide and metformin. On examination, his vitals are his heart rate is 80 beats per minute, blood pressure is 122/69, respiratory rate is 28. On general examination, he has an IV cannula on his left arm and is alert and responsive. He has nailed pallor and no lymphadenopathy. He has no oral candida or Kaposi's lesions. He has limb and truncal ataxia. On CN examination, his GCS is 15 out of 15. The cranial nerves are intact and sensation is preserved. On motor examination, the power of the arms are preserved. The power of the legs are reduced. It's 4 out of 5. There's no spasticity and no rigidity. Positive signs of meningism are photophobia and neck stiffness. There's no Koenig sign. The positive cerebellar signs are dysdiadokinesis, dysmetria, ataxia gait, nystagmus, intention tremor, and reduced power. There is no slurred or staccato speech. The CVS, RESP, and abdo examinations were well or unremarkable. On investigations, the bloods, investigations, the SBC, FBC, UNE, kidney function test, and gene experts were ordered. And lumbar puncture, cytology, TB-PCR, and antigen tests were ordered. The CT brain was ordered to observe any brain lesions. And the MRI brain was ordered to observe any brain lesions as well. So what this is just an example of a patient, and it's really important here that you see that having presented the history, the medical history and examination investigations, then you'll be able to form a nice summary of what the patient has currently, what he's presenting with, any medical conditions that he's had before and their control, the clinical findings that support the diagnosis, differential diagnosis that you have, and as well as which investigations have you ordered or are ordering in order to confirm or narrow down your diagnosis, as well as the management of the patient. So we hope that this talk has really equipped you with the necessary skills to be able to present a patient that you interact with in the ward to a clinician. And this is a really important skill that you need to develop, as it will be really important to have throughout your medical or health professional careers.